Think of the optic nerve as a high-speed data cable that continuously carries visual signals from your eye directly to your brain. Glaucoma is a disease that permanently severs that connection. It is one of the leading causes of irreversible blindness worldwide, and it destroys this vital cable completely without warning. To understand how this cable gets severed, we have to look at the internal environment of the eye. You can think of the eye like a tightly regulated pressurized sink. It continuously produces a fluid called aqueous humor to maintain its shape, and that fluid constantly drains out through a natural biological meshwork. But if that natural drain becomes less efficient, the fluid has nowhere to go. Intraocular pressure, or IOP, begins to build inside the chamber. With the front of the eye blocked, that pressure pushes backward, physically crushing the delicate optic nerve at the back of the eye. The most dangerous part of this structural failure is what the patient feels: nothing. Because the damage starts at the outer edges of the nerve, a patient's central vision remains perfectly clear. They might easily read a 20/20 eye chart while their peripheral vision is quietly eroding away. Because this deterioration is entirely invisible to the patient until severe damage is done, the entire modern medical approach to glaucoma relies on a single aggressive strategy: forcefully artificially lowering the eye's internal pressure down to a safe, individualized baseline. The first line of defense is often a quick, in-office procedure called selective laser trabeculeplasty, or SLT. Doctors use a specialized laser to stimulate the tissue inside the eye's natural drainage meshwork. This prompts the biology to clear itself out, allowing fluid to drain more efficiently and dropping the internal pressure by up to 30%. This chart shows the long-term effectiveness of SLT over a 6-year period. By treating the drainage system directly, nearly 70% of patients who receive this laser treatment first are able to remain completely drop-free for years. When laser intervention isn't an option, doctors turn to pharmaceuticals. Specific eye drops, like prostaglandin analogs, chemically force the eye's drainage pathways open to relieve pressure. Other categories of drops, like beta blockers, attack the problem from the opposite end by reducing the amount of fluid the eye produces in the first place. But this pharmaceutical approach relies on a highly unpredictable variable to keep the optic nerve safe: human compliance. Taking multiple daily eye drops for a disease you cannot physically feel is a massive psychological hurdle. Patients often skip doses because their vision seems fine, or because the drops cause mild side effects, like redness and stinging. When those doses are missed, the internal pressure quietly climbs right back up, and the silent destruction of the optic nerve resumes. To bypass that human error, doctors eventually have to escalate from daily drops to permanent surgical hardware. That hardware is deployed through minimally invasive glaucoma surgery, or MIGS. This tier of procedures is designed to permanently physically prop open the eye's natural outflow system. Using specialized tools, surgeons implant microscopic metal stents directly into the eye's drainage angle. Once locked into place, these tiny scaffolds ensure the biological drain stays open, allowing fluid to continuously escape without relying on chemical eye drops. Doctors frequently install these devices during routine cataract surgery, removing a patient's natural cloudy lens and replacing it with a thinner artificial one inherently creates more internal space inside the eye chamber. That extra space widens the drainage angle naturally, lowering eye pressure even further. MIGS successfully bridges a crucial gap in glaucoma care. It provides a permanent, structural fix that completely removes the unreliability of daily medication, offering a highly safe alternative before resorting to major, high-risk surgery. For advanced cases where the optic nerve is under severe threat, surgeons abandon the eye's natural plumbing entirely. In a procedure called a trabeculectomy, they physically cut a brand new outflow channel through the eye wall. The internal fluid is rerouted out of this new drain and collects in a small hidden reservoir under the eyelid called a bleb. If the patient's anatomy isn't suited for a newly cut channel, surgeons will implant a tube shunt. This procedure places a permanent silicone tube inside the eye, which funnels the excess fluid back to a tiny flat plate anchored out of sight beneath the eyelid, where it is safely absorbed by the body. These heavy-hitting surgeries force doctors to walk a very narrow clinical balance beam. The pressure must be dropped drastically to save the optic nerve, but if it drops too low, patients risk ocular hypotony, a dangerous condition that can cause the eye to structurally collapse and create entirely new vision problems. In the most stubborn cases, when all drainage strategies fail, doctors employ an absolute last resort, cyclophotocoagulation. Using targeted micropulses of laser energy, surgeons permanently destroy portions of the specific biological tissue responsible for producing the eye fluid, literally turning off the internal faucet. At this late stage of the disease, saving a patient's sight means balancing on a medical tightrope, engineering a completely artificial fluid dynamic to halt total blindness. The harsh reality of all these treatments is that they are entirely preventative. Glaucoma damage cannot be reversed. Any vision that the optic nerve has already lost is gone forever. To make that prevention easier, researchers are developing new delivery systems. Instead of daily drops, microscopic sustained-release implants can now be placed directly inside the eye, dissolving slowly to automatically medicate the fluid over several months. Beyond plumbing fixes, the medical frontier is now pushing into neuroprotection. Scientists are actively testing gene therapies and biologics designed to directly armor the retinal ganglion nerve cells, helping the optic nerve survive the pressure rather than just trying to lower it. Until those therapies arrive, the goal remains lowering pressure. And because every optic nerve has a different threshold for damage, there is no universal, normal eye pressure. A safe baseline for one patient might be low enough to cause severe deterioration in another. Glaucoma is a permanent condition, but with an escalating medical arsenal of targeted lasers, microhardware, and major surgical bypasses, it is a highly treatable one. With early screening and precise management, a patient's vision can safely outlive them.